Bias is an unavoidable part of being human. Our brains categorize information in order to function efficiently, and in doing so we develop assumptions, beliefs, and expectations, some conscious, some not. In social work practice, especially with clients who use substances, these biases can shape how we assess, interpret, and intervene long before we even realize it. There are two major types of bias clinicians must recognize: explicit bias and implicit bias. Explicit bias involves conscious attitudes or beliefs, such as thinking a certain substance is worse than another, or believing a particular group is more likely than another group to misuse substances. Implicit bias, on the other hand, happens beneath awareness. It shows up in automatic judgments, discomfort, or snap interpretations that occur without deliberate thought. Both forms of bias influence engagement and rapport. Bias becomes particularly powerful in work with substance use because stigma is already deeply embedded in social narratives. Words like addict, clean, and dirty reflect a moral framework that positions substance use as a personal failure rather than a complex biopsychosocial experience. These value judgments can impact clinical decision-making in subtle ways, shifting how we assess risk, how we interpret ambivalence, or how we view relapse. This is where professional use of self becomes central. Social workers don't eliminate bias. We develop awareness of how it shows up in our reactions, language, and assumptions. We learn to notice countertransference, our emotional response to clients, and thoughtfully separate our values from our role. Professional self-awareness allows us to identify these reactions, then pause, and make decisions grounded in ethics, not emotion. Stigma and stereotypes also influence help-seeking behaviors. Clients may underreport or minimize their use due to shame, fear of being labeled, or avoid treatment systems they perceive as punitive. Communities with histories of discrimination or negative experiences with institutions may distrust providers. Without cultural humility, clinicians risk interpreting ambivalence or avoidance as noncompliance, rather than as a rational response to stigma, oppression, or systemic inequities. Culturally responsive practice, and the NASW Code of Ethics, requires us to examine our own assumptions while seeking to understand clients' cultural beliefs, identities, and experiences. Tools like the DSM-5 Cultural Formulation Interview, the CFI, help us explore meaning, context, and language rather than relying on stereotypes or our own cultural lens. Ultimately, learning to identify and manage bias is not about guilt or perfection. It's about ethical practice. Effective substance use assessment depends on approaching clients with curiosity rather than judgment, using person-centered language, and recognizing how stigma shapes both clinician behavior and client experience.